without further ado, I'm very pleased to introduce today's speaker. Thank you so much for joining us today, Dr. Brummett. Dr. Chad Brummett is professor at the University of Michigan, where he serves as a senior associate chair of research. He has more than 250 publications, including articles and top journals such as JAMA, JAMA Surgery, Anesthesiology, and Annals of Surgery. He's the co-director of the Opioid Prescribing Engagement Network at the University of Michigan, which aims to supply a preventative approach to the opioid epidemic in the United States through appropriate prescribing after surgery, dentistry, and emergency medicine. In addition, his research interests include predictors of acute and chronic post-surgical pain and failure to derive benefit from interventions and surgeries primarily performed to treat pain. In particular, he's interested in the impact of fibromyalgia-like or central pain phenotype on analgesic outcomes. He's a co-PI of multiple NIH grants studying these concepts. He also receives funding from the Michigan Department of Health and Human Services, SAMHSA, CDC, and multiple foundations. Dr. Brummett's going to be speaking to us today for about 45 minutes, and then we're going to have time for Q&A. So as he's speaking, please chat in your questions into the chat, into the Q&A function, and then I will be moderating our Q&A discussion after his talk. And now I turn it over to Dr. Brummett for his presentation on the role of acute care prescribing in the opioid epidemic.
Well, thanks, Beth. It's a pleasure to be here today, and I really appreciate the opportunity to come and speak, and I look forward to a robust discussion. As Beth said, I'm an anesthesiologist and a pain physician here at the University of Michigan, and I'm one of the co-directors of OPEN. In terms of disclosures, I have funding from NIH, CDC, SAMHSA, as Beth noted. I have a patent. It doesn't pay me anything. I've never sold anything from it. I consult for a few companies, including Heron Therapeutics and Vertex Pharmaceuticals. I don't do any promotional work for their team. It's purely on the consultative side, and I've never done any promotional work for them. I also do some expert testimony. I'm not going to talk about any of my consultative work today. So I don't think I need to probably go deep on the opioid epidemic for this audience. Probably most people join today because they're already in this space, already working in this space. But I do think it's important to recognize that before COVID, we were talking about opioids everywhere. Every journal, every lay press that you would pick up had something about opioids. And then COVID came around, and I think we really sort of ignored this problem, and it's evolved. It's evolved now to heroin and fentanyl being a problem. Many of our opioid overdoses now relate to illicit fentanyl, and the narrative has changed during that time. But sadly, during that time, actually, opioid-related deaths are at an all-time high. And it is true that most of these are due to heroin and fentanyl. I will also say, though, that among those people who do move on to heroin or fentanyl, they generally start with a pill. I mean, I think the data show us this. About 3/4 of the people who start injecting heroin began with a pill, whether illicit or illicit, and I think as a provider is really important. And I used to think just giving numbers was enough, but honestly, for the most part, I now tell stories, and the reality is there's too many stories to tell. And I think the stories that I focus on are admittedly on the side of loss. Kids and young adults who get opioids probably in situations in which they don't need them, because there are still many times where we're giving opioids to kids and young adults who end up having, moving down a pathway that leads to some misuse, abuse, sometimes leading on to the development of opioid use disorder, heroin use, fentanyl use, and death. And unfortunately, in the last several years, as I've moved through this, I've heard too many of these stories, and I probably won't go into any of them today. However, what I will say as well is that I think I am part of the opioid epidemic. In other words, I think as a chronic pain physician, I think my well-intended care has directly contributed to harm at some point. I also will say I prescribe opioids today. I have chronic pain patients, people I've managed for over a decade, patients I really care a lot about, who I manage responsibly with opioids. I also am a believer that opioids are a tool and they're an important tool in managing, in particular, acute pain, and that they have a role for some patients as it relates to chronic pain. Now, our group came together around 2015, 2016, with this understanding that most of the country was all focused on the downstream effects of opioids. We were all thinking about just chronic opioid users, how to better manage people with chronic opioid use, how to manage people with opioid use disorder, how to get more naloxone out there. And at that time, just starting to talk about how to get more treatment for opioid use disorder, something that's really grown a lot in the last few years. But at that time, really, nobody was talking about this, the idea that the majority of people coming in for care for surgery, this is probably 80 to 90% of the people coming in for surgery were not taking opioids. And I could tell you, if I came to Stanford, I could tell you not only who was going to get an opioid, but how much they'd get. If you just give me a couple weeks worth of data, I could say, Dr. Jones always gives 30 pills for this, and, Surgeon X, she only gives 20 pills for this. And there's really not much precision medicine to it, with the exception of the fact that I think most surgeons prescribe more to people who use opioids chronically. We'll talk about that because that's probably appropriate. But again, it's something where we really just don't have a lot of data. Now, I think, though, that if we consider the fact that 80 to 90% of people are not taking opioids before surgery, this really became an opportunity early in our efforts to think about a preventative approach. How do we ensure that this person moves down a path where they have attentive pain care throughout their surgical course and that they're left no worse than they started? How do we ensure that they move down and that we keep the patient, their family, and their community safe by not leaving excess pills in medicine cabinets? And this was a big part of our start. And I'll talk mostly about this today, but also show you where we've gone. Now, as an anesthesiologist, I always like to tease surgeons because it's one of my roles. But honestly, as a pain physician, these things all hold true. We thought a lot early on about what drove prescribing for surgeons. This is true for dentists. This is true for chronic pain physicians. This is true for primary care physicians. There's a lot of concern about time. It's a heck of a lot easier to just write a prescription. There's concerns about phone calls for refills. So if you do a surgery and you're getting a lot of phone calls because people are refilling, that takes a lot of time from staff. That causes dissatisfaction for patients, dissatisfaction for surgeons. And so what we've heard over time is that fear for refill, or that concern about refill, leads to just give them enough so they don't run out. We've certainly heard that. I probably taught people that throughout. And then while satisfaction may no longer be associated with payment, that HCAP measure that used to be associated with payment, people still care a lot about satisfaction, and for good reason. We all went into medicine to care for people. We're trying to make sure that our patients are satisfied. And unfortunately, I think we can get very caught up on Yelp reviews or Twitter or whatever it is that might make a person feel like they're not doing the right thing. However, that's not a data-driven effect, right? The reality is that satisfaction comes from many ways. And so we've published a few papers in this space. Others have as well. The message is very consistent. There's no association between the number of pills prescribed and people's satisfaction with their care. There's also no association between the number of pills prescribed and the likelihood of call for refills. And so I'll unpack it because I'm certain already people are saying, well, that can't be true. What is true is that people refill after surgery. If you take abdominal surgery, for example, 7% of people in a national private payer claims database, so we're looking at claims data, 7% of people refill. And it doesn't matter whether you're using less than 6 pills of hydrocodone or more than 60. And it doesn't matter whether you risk adjust or don't, right? About 7% of people refill. If you take a total knee replacement, about 35% of people refill. And it doesn't matter whether you look at less than 15 pills or 100 greater than 150. In fact, you have to give people 10 more pills of oxycodone to reduce the whole overall group's likelihood of refill by 2%. And yet 35% of people will still refill. And so when I'm talking to surgeons, when we think about appropriate prescribing, we're not saying don't refill. We're just saying you can't avoid refill by excess prescribing. Refill is a part of care. In the same way, people are periodically dissatisfied. I'm sure you could go and find Yelp reviews that say that I'm they didn't like the care they received in my clinic. I will say I have a great relationship with my pain patients. I've been managing some over 15 years, and we have a deep relationship. But at the same time, there are probably people with whom I didn't connect. And at the same time, if I did that and I took an experience where I might have not refilled an opioid on a person who I felt concerned for, or not given them the procedure they wanted, that wouldn't really be a data-driven effect. And in surgery in particular, there's no association with dissatisfaction. What really drives satisfaction is care for people, talking to them, attending their needs, listening to them. Sometimes you can disagree with the patient, but you can do so in a respectful way. It's not that I've never had hard conversations in our pain clinic, but it's when people feel dismissed or abandoned. And we've certainly seen stories of abandonment. To be clear, I'm very much against any forced tapers. I'm very much against any rapid discontinuation. That's not what we're talking about here. We're talking about prescribing to people after surgery. And the fact is that satisfaction is more driven by the way you care for them, the way you attend to them. Do you call them after surgery? Do you check in on them? And are you kind to them? And it's not just you, it's your staff. Your check-in, check-out staff, or your phone staff respectful of the patient. Those are the things that really drive care. We've done a lot of work in our community and working on customer satisfaction in our pain clinic. And I say customer not in a way of thinking about them as business, but more to say we should treat people the way we would want to treat if we were going to any place. And it's had an incredible effect, such that we're one of the highest rated pain clinics. I mean, we're one of the highest rated clinics in our health system, the fourth highest rated clinic of the 150 clinics in our health system. And I think that's been really successful. But I was really interested in this idea of new persistent use. And there's lots of definitions or words that have been given. New persistent use is what I call it, but some would call it new chronic use, some would call it prolonged use. But the concept is simple. People who come in not using opioids before surgery, who months later continue to use opioids. And in some cases, we're talking about claims data where the patient's filling the opioid. However, we have some data sets in which we're looking at prospective data. And so this is probably the paper for which we got the most publicity, is this national private payer data set. And what we found was that in this case mix of surgery, about 6% of people became new chronic users. And what's interesting here was there was no difference between minor surgery and major open abdominal surgery. The rate was about 6%. People were really surprised by that in our team, but I wasn't, because we had published this paper the year before. This was a secondary analysis of data that we had collected as prospectively. So we tracked people over time before their knee and hip replacement. And so we not only knew what was in their medical record, we interviewed patients, we knew who was not using an opioid beforehand, and then we followed them over time. And 6 months later, we knew what opioids they were taking. Now, we were interested in a particular pain phenotype. We were interested in that centralized or nociplastic pain phenotype and how that affected outcomes. So this was a secondary analysis, but what we found, and I was really surprised at that time, was that 8% of the total knee replacement patients became new chronic users. Definitely not using beforehand, definitely using 6 months later. And in the same way, 4% of the hips. And we had the gold standard measure, the best way to measure knee, hip, pain, stiffness, function. And we found that there was no association between whether their knee or hip got better, worse, or stayed the same and the likelihood of new chronic opioid use. As I said, I really care about chronic post-surgical pain. This is a lot of where our research is going. We do a lot of work in this space to try to understand why it happens to some people and how we can prevent it. But it didn't appear that this was just post-surgical pain. And unfortunately, just about every condition that we've looked at, we have found some rate of new persistent use. And people may argue our definitions. Some might say it's half that, but no matter how you cut it, becoming a new chronic opioid user is really probably one of the most common complications after elective surgery, and yet a complication we don't talk to patients about. Some may bristle at the idea that this is a complication, but the reality is if you start a medication for short-term use and they're taking it months or years later, and it's associated with some of the ill effects that we know chronic opioid use is associated with, that's a complication. The other thing is that we see higher rates in cancer care. And I am very much a believer that people in end of life should have access to opioids. During my fellowship, I don't do a lot of it now, but I did a lot of end-of-life care as a part of my pain fellowship. And it was some of the most satisfying care I provided, and that included opioids. However, things like this 10% number here, those patients had curative cancer surgeries. They had a surgery in which they had cancer cut out. They left the operating room cancer-free, but 10% of them kept using opioids months later. In the same way, breast cancer surgery, something I really hope I never have a family member go through because I'm deeply empathetic here. But the reality is that most of our surgeons now, with multimodal analgesia, nerve blocks, et cetera, are finding that that opioids, they can use very little or none, and that women are actually doing better, less nausea, less vomiting, less constipation, and better satisfaction. And yet a portion of them are going on to chronic use. Now, this is complex care. Some have chemo, some have radiation, and there's some of them that need the opioid very clearly, but I don't think it's as many as we're seeing develop new chronic use. So these are the factors that we see associated with new chronic opioid use. And some people might say, well, anxiety and mood disorders are obvious, but it's interesting how, when you talk to patients with opioid use disorder, not all of the anxious patients say that, the stigmatizing concept of opioid use disorder is that you took it to get high. But for some people, in particular young people, with anxiety, opioids can have a leveling effect, make people feel normal. Unfortunately, they're not good anxiolytics, right? They're good short-term anxiolytics. We've used them in recovery rooms for years to allay anxiety. We say we're doing it for pain, but the reality is there's a portion of that's for anxiety. Sleep disorders, not surprising, but everybody's had a friend or family member who said, well, I don't really have much pain, but after surgery, but I'm having trouble sleeping at night, so I'm taking the opioids to help sleep. Unfortunately, it's a bit like having a few beers and getting some sleep. It is not, the sleep data are very clear. Opioids do not promote restorative sleep, okay? The other piece is this idea of remote opioid use. So we know people were not taking opioids before surgery, but after a while, we amended some of our questions to ask, have you ever been a chronic opioid user? And it's interesting because people who admitted to having ever used an opioid, especially those that ever using it chronically, had about an adjusted 5 times odds of becoming a new chronic opioid user. And I think part of this is just the ability to tolerate an opioid among our chronic opioid users. And again, I think there's probably, based on the available data, because it's not great, I think it's probably about 10% of our chronic opioid users that seem to be getting beneficial effect without dose escalation or problem. So those are people I continue on opioids, and we do it in my clinic. However, there's a larger proportion that don't get benefit and or get side effects or problematic use that are the concerning part. And I think differentiating those people is problematic, not just because of the concerns about addiction, but actually, if you look at it, among people given opioids for surgery, 80% have a moderate to severe side effect. About 80% also get some analgesia from an opioid. So they're not super well tolerated drugs for a lot of people, and we hear this from patients all the time now. It's becoming more common for people to come in now than it was maybe 10 years ago, saying I don't want opioids because I was so nauseous last time. Chronic pain conditions, 1 in 3 Americans lives with chronic daily pain. I told you I'm a chronic pain physician. Thankfully, not 1 in 3 Americans is living with opioids daily as a part of their chronic pain treatment, but they may have surgery. And I don't know that we're always linking that idea of why are you still taking opioids months later? Is it for your surgical pain or for your chronic pain? Because if it's for your chronic pain, we need to be thinking about it differently, assessing it differently, and determining whether or not it's appropriate in a different way. Because if I'm giving it to you for surgical pain and you're taking it for a different pain, well, we may not be on the right track. And substance use disorders and tobacco, again, seem obvious. But right now, we're not doing any high throughput, non-stigmatizing screening for substance use disorders. We know alcohol use disorder is up since COVID. People are misusing alcohol, and it's a problem. It's a huge problem. Methamphetamine and cocaine use, definitely up. And we're giving people a controlled substance, but we're not actually screening. And I don't view screening as a way to withhold opioids. Screening is a way to determine appropriate pain care, to ensure that we're doing it safely, and then also to link people to long-term treatment who deserve and need treatment. Now, people say, oh, persistent opioid use is just a little chronic opioid use, and it's not really a problem. But unfortunately, that's just not true. Our data now show an association between new chronic opioid use or new persistent use and the development of frank opioid use disorder. Because when I'm talking about new persistent use, I'm talking about dependence, which can be uncomplicated opioid dependence. But some of those patients do go on to develop opioid use disorder. I'm not going to show the data today, but we've actually shown that the genetic associations of opioid use disorder and the genetic associations of new persistent use are actually largely the same. And that paper's coming forward. And I think it's interesting because it shows that maybe some of our link of chronicity in opioid use disorder that some people have been talking about is there. Overdose, death, healthcare utilization, falls in a Medicare population and readmission. All of these things are important outcomes. And so it's not just that people are taking a few pills and going on and living a full and productive life. That does happen for some patients, but there is a portion of these patients that go on and have significantly higher associations of these really serious and very concerning healthcare outcomes. So what is it about our state? Why are we different? We have a dominant private payer in our state. Blue Cross Blue Shield of Michigan has funded these quality collaboratives throughout the state of Michigan. This is just a couple of them. This represents the MSQC, the Michigan Surgical Quality Collaborative. This has been in existence for over a decade, thinking about ways to improve quality of surgical care, largely focused on things like surgical site infection, DVT prophylaxis, and other best ways to optimize care, such that we had a Texas chair of the American College of Surgeons come in and say this is the safest place in America to have surgical care, because all of these competing hospitals actually get together and say, well, this is how we're doing it, this is how we're doing it, and they build quality metrics, they track each other, they keep each other accountable, and they try to promote all care across the state. And it's a pretty remarkable platform. These hospitals will send a surgery champion and a nurse champion physically present 3 times a year to talk about quality. They develop metrics. And so we went to Michigan Department of Health and Human Services 6 years ago, and we said, or maybe it was more than that, more like 7 years ago, and said, we want to use this platform to understand real world prescribing, what's actually happening. We don't want to make prescribing recommendations from the ivory tower at Michigan Medicine, because actually when we looked at it, we were leaders in the best. We prescribed more opioid than any hospital in the state of Michigan. And that's true of all academic medical centers, or was true of all academic medical centers, that academic medical centers prescribed about 20% more than the private hospitals. And actually APPs, or nurse practitioners and PAs, prescribed about 20% more. So we knew we couldn't just say here at the ivory tower, we're going to do this. Not only that, people around the state, maybe because of football rivalry or just not want to listen to some nerd from the University of Michigan, don't want to listen to us say what we do better. We kind of have come in and say, here, look, this is what we were doing. And we recognize that most of what we were prescribing was going unused, and we weren't really being thoughtful about our care for patients. So we could use instead this platform to collect real patient-reported outcomes that are generalizable, and then disseminate those across the state. So our concept is we would make prescribing recommendations, and that through that we would reduce prescribing, because we knew prescribing was in excess of what people needed. That was described already. Interestingly, though, we also knew that if we made reduced prescribing recommendations, we would reduce patient consumption. There's a well-described social psychology phenomenon called anchoring and adjustment. Basically, if you give people more, they take more. And this is largely from the food literature, but now we've shown this multiple times in surgical care, across multiple data sets and multiple types of surgery. For every additional pill that you give past what our recommendations show, people consume an additional half pill without any improvement in pain, satisfaction, or function. So think about that. If you're talking about something like orthopedic care, where people were traditionally going home with 100 pills, where they might need 20, they were taking an extra 40 pills just because we prescribed them, not because it was making their care better. And so in doing so, as we reduce prescribing, we wanted to make sure that we were updating our prescribing regs, not just come in at one time, say, here's the right number based on my opinion, and you got to go forward with it. Not only that, what was important for us, important for me as a pain physician, was that we were monitoring satisfaction and monitoring patient-reported outcomes. So the question is, how have we done? Well, these are our prescribing recommendations. There are ranges here. These were recently updated and will be updated again. We have some pediatric recs, and you see a range from 0 to a number, meaning that we recommend opioids for as an available source for all patients except for dental extraction. And we can talk about that in the Q&A, because the dental piece is uniquely American. There is level 1 data to show that acetaminophen and ibuprofen together is better, or at least as good as an opioid without all the side effects, for treating dental extraction pain, which is about 2/3 of the prescribing for dentistry in America. However, the reason we put the 0 in was what we found was that some people were actually increasing their prescribing based on our numbers, interestingly. So some people had already moved to a lower number. They started increasing their prescribing, but weren't noticing benefit. And I think this comes back to a really interesting paper. I won't show it today, but Rick Barth and colleagues at Dartmouth showed that among people who were in the hospital, because we stay in the hospital for lots of reasons, it's not just for pain care, who used 0 pills in the 24 hours before discharge, they went home and used 0 pills. And so giving those people opioids as a part of it, we just didn't make sense. Didn't mean that some wouldn't go home and need it. Didn't mean you couldn't prescribe it, but actually a lot of people don't need it. And interestingly, our cardiac collaborative, so this is people who undergo midline sternotomy, meaning you get your chest split open, sewn back together. Interestingly, people stay in the hospital for a long time afterwards because of cardiac issues. And most of the people are actually off their opioids before they leave the hospital, but we're still traditionally going home with upwards of 100 pills, despite not taking any in the 24 hours before going home. And so this, I will say our cardiac collaborative, which is a different statewide collaborative, has been thoughtful and probably ahead of the game in triaging or tailoring the care based on use. And they have basically 3 different recommendations based on the patient's use. So these are our recommendations. These are ranges. These represent anywhere from a 2 to a 5-fold reduction of what was classically done in America. And then the question is, have we actually seen any improvements across the state? This is a case mix from the MSQC, which is our General Gynecologic and Vascular Surgery Collaborative. Again, these are data actually from about 45 hospitals. And what we show is that before we came together, people were getting on average about 45 to 50 pills. We came together and just had people start to measure their prescribing. We saw a decline, but after we released our prescribing recommendations, we've seen significant month-over-month prescription decreases, such that now for that case mix of general gynecologic and vascular surgery, we're prescribing between 10 and 15 pills, okay? And we're not really seeing that slope downwards anymore. So this is starting to taper off. This is kind of where we are. People are finding the recommendations. Some of our recommendations for these cases are 20, some might be 10, some might be 5. Anyways, this case mix has come down. And I've certainly heard the feedback from people concerned that I don't care about people's pain. Just maybe, I understand that, it's a hard world where we don't all get to know each other. We don't all get to interact, but these are data from about 43 hospitals. It's 11,000 patients. And this is what we found, right? These are the objective data. We see a decrease in prescribing over time. Again, that data I showed you before. With that came a decrease in consumption. I told you that anchoring and adjusting phenomenon of decreased consumption with decreased prescribing. And this self-reported pain, this is rating their pain in their 7 days after surgery, and their satisfaction with their care remained flat and good. And so I think what this shows is that you can actually attend to people's pain and satisfaction with less prescribing. And not everybody should get 0, but some people can get 0. And opioids are a tool, but they're not the tool, and they won't necessarily attend to everything. We looked across, this is a paper that is just come out in Annals of Surgery. We used Medicare data comparing 25,000 people in the state of Michigan to about 120,000 people nationally. What this shows, this is using a difference in differences analysis and analytic approach, which is an econometric approach that accounts for the fact that we knew prescribing was decreasing nationally. And so what this does is this accounts for that decline, says how much additional decline are you seeing in your treatment group, or in this case, the state of Michigan, when compared to the rest of the country. And what we found was that we're prescribing about the equivalent of 11 pills less per surgery in the state of Michigan when compared to the rest of the US. And that we've actually seen a decline in the rate of persistent use by about 0.5%. When I told you that the outcomes for people with persistent use, I think this is meaningful. So I talked about reducing opioid use. I talked about educating prescribers, but one of the places where we're starting to work, I think now, is in this idea of eliminating unnecessary use. And what I mean by that is, I still think we have a lot of places in America where I told you what my feelings about dentistry. Part of the reason I feel that way about dentistry is because they have the trials and the data to demonstrate this. They've done randomized controlled trials, randomizing people to opioids, or no opioids with acetaminophen and ibuprofen and shown that you can do without. We haven't done that for surgery, but we are starting to do trials like that. And I think they'll be important, not for major surgery, but for minor surgery, to think about, do we really need these? Because honestly, if you're not concerned about the addiction piece, that maybe that doesn't move you, right? Fine. As I said, most people will have a moderate to severe side effect, and in particular, those people not using opiates. I don't think this really applies to chronic opioid users in the same way, because they either do or don't have those side effects by that point. And most people, if they do maintain chronic opioid use, they're probably tolerating at least well enough that giving additional opioid postoperatively won't be problematic. However, a significant portion of patients will have serious nausea, vomiting, constipation, dizziness, falls. And so I think we have to reflect on whether they're necessary for all surgeries. As I said, I think they're a tool for some surgeries. We know that for, this was again from Rick Barth's group, this predates a lot of our work, showed about 75% are unused. And so if I put that in context, in the state of Michigan, 1.8 million surgeries a year, we were prescribing about 45 pills, meaning we had about 33 in excess for every case. It meant just surgical prescribing the state of Michigan alone, before we started into this, 62 million unused pills from surgery alone, just in our state. And if you need that for context, this is Michigan Stadium, where we love our football team on Saturdays. This is 1 year's excess prescribing, if you think about the area of a hydrocodone tablet, and we'd need about 3/4 of our hockey arena. The reality is there are billions and billions of pills still sitting in medicine cabinets today. And we know that this is important. So maybe you're not concerned, or maybe people want to understand a narrative beyond that individual patient. Even the patient may want to understand that narrative. Well, we have people, as I said, we think prescribing will continue to happen. We think opioids are a part of care. But for the people who just stick it in the medicine cabinet and don't think about it, these are data from kids 15 and older admitting to misusing an opioid in the year prior. 55% get them left from a friend or family member, very easy to access. And about 17% have them left over from their own care. And really, this is still part of our narrative as we think about surgery. Our group hosts opioid take-back drives. I don't think these are controversial at all. We do them on the same day as the DEA drive. We try to get away from the law enforcement side of this, because I don't work directly with the DEA. I'm not a part of the DEA. But we partner with law enforcement to bring it out into the community to make it accessible to people to get rid of their opioids, because we see that people want this, they need this. And I'm always thinking that the need for this will go down, and our numbers grow year over year. We do these twice a year. And so these are our impact. I hope what we've done, though, is maybe made people think a little bit more about getting rid of unused pills as just a tool. We do think that there are more everyday options. And this is just a simple, pragmatic trial we published a few years ago. We compared people who got usual care, meaning that we didn't really intervene, got a couple weeks of just seeing how people disposed. We called them to find out whether they had disposed of their unused pills. 25% had not. 25% had disposed. That's actually much higher than what we see nationally. It's probably more like 4 to 10% nationally. But part of the reason why is I think we've been working with this group of nurses, and so I think they talk about it naturally already. We gave a detailed information sheet, and I was convinced, hey, if we can give them this detailed information, they'll dispose of it. They'll know where to dispose. It didn't help at all. People didn't leave their house to dispose of their opioids. So instead, giving them and I don't have any affiliation with Tara. There's Dispose RX. There's other branded ways to dispose of opioids, but this is putting opioids in a bag, adding some warm water, throwing it away, and it's basically deactivated through carbon. And so, this is a very simple, easy, and you see it improved self-reported disposal. Not only that, it led to less people flushing their opioids, which I think is a positive thing, despite what the FDA says. And we know that people who use opioids before surgery are more complex. And we also know that there's about 20% or so that come in, and these are more complicated patients. In fact, when we first started as a group, we actually started in the space. We just categorized patients as an opioid user or not, and found that if you looked at the 90-day cost on an opioid user, it was about an adjusted $2,300 increase. People stayed in the hospital longer. They came back to the hospital more often. They had more surgical site infection, more myocardial infarction, more sepsis, really things that you could mechanistically say were associated. We can't say causally, but we could say mechanistically this makes sense for opioids. And I will say this is probably one of the most important pivot points, because one of my surgery colleagues, when he first saw these data in 2015, said, we should take all our patients off opioids before surgery. And I said, no, you can't do that. Like that's problematic. That will lead to more problems. We can't do that. But now we're back thinking about not, can we take everybody off opioids before surgery, but how do we provide more attentive care? How do we avoid the complexities and the disconnected care that we see for these patients? And so this is how we're thinking about this, because unfortunately, we see certainly from a few of the larger academic medical centers, leading institutions, they create transitional pain services. These are very resource intensive services that require lots and lots of care and time and money, and they're great, but they're just not scalable. So, this is kind of how we're thinking about it right now. And I will give credit to my colleague, Mark Bickett and Jen Walji, because they're really leading this, but the idea of screening people. We need to create high throughput, non-stigmatizing screening. Everybody should be screened. If we're only screening the people we think are problematic, we know there'll be problems. We know that there will be disparities in who we screen. Not only that, we can't just screen people without giving information. If we just give surgeons information on a screen and a person screens positive, it could lead to problems. They might not give the person opioids. They might not do surgery. And that's not the right answer. This is about, each case can be a little different, but we're trying to create that information around that. We need to be communicating with our patients better, creating better expectations, and then also coordinating care. I can't tell you, as a chronic pain prescriber who prescribes opioids to my patients, it always amazes me where I might see one of the surgeons at the pool the next week, and she will have done a surgery on my chronic opioid user a week prior, but I would have no idea. This is a person who could pick up the cell phone and call me. And so if that kind of tight connection isn't normal, then we know for sure it's not happening for other people. And we've seen this, right? And so as we think about this, we realize that we need to start to tailor care for the chronic opioid user. And these are data from Mark Bickett, published in RAPM. These are statewide data. It's about 7,000 chronic opioid users and about 20-ish thousand people not using opioids. And what we see is that when you compare just opioid users, opioid users here to non-users, and we compare it in oral morphine equivalents. And so for context, 30 oral morphine equivalents is about 6 pills of hydrocodone. This is how much people reported taking after this case mix of general, gynecologic, and vascular surgery. So some of those same conditions I've been talking about. And so you see opioid users reported taking more, anywhere from 2 to 4 tablets more, right? So not maybe as much as we once thought. In fact, when we looked at the minimal group, and so minimal group could be as many as like 2 or 3 pills per day of hydrocodone, those patients actually didn't take very much more or any more. So this was not significant. The difference in the minimal group and the naive group was none. I mean, these people were essentially taking the same amount. And believe me, our prescribing areas, we're not trying to come down to the pill, because we recognize that there is a fudge factor there, right? But as you get to these intermittent group or the chronic people, the people using month over month, what you see is about a 2-fold increase in the people who are on higher doses or using opioids chronically. And that's what we would expect, but maybe not the 4 or 5-fold increase that we hear about. And again, I just was speaking to a group of urologists. They were asking about this. And I said, yeah, so you prescribe more to this patient population, maybe not as much as what you once did, right? Because you're not going to be able to just give so much that person never needs again. But being open to the idea of refill and or coordinating with their normal prescriber to help them think through a perioperative course. In the same way, we recognize the importance of these transitions of care. This is data from Pucciolage study. What we found using this private payer database, about 90% of people, is a national database, 90% of the people that we define as chronic opioid users, these are people filling almost every month. 90% had a usual prescriber, somebody who prescribed to them almost every month. And what we found is that only about 30% of those people go back to that usual prescriber within 30 days. Most don't. And that among those who don't go back, 75% of them had really high risk prescribing. So this is really high daily doses, overlapping prescriptions, people starting to get more benzos and opioids together, things that we know to be high risk. And we, again, think this is uncoordinated care. Now, I've talked about some of our work. I won't talk about all of it. I did mention our dentistry work. We work with policymakers, but I'll just hit a couple highlights. This is important work. We got an opportunity with a block SAMHSA grant through the state of Michigan to stand up naloxone distribution in our EDs. We knew that the data showed that only about 2% of people admitted with an overdose with insurance would subsequently fill a naloxone prescription. And this is before naloxone was ubiquitous. This was before naloxone was free or over the counter, right? And even as it becomes over the counter and the FDA is talking about this, we know that people won't pay for it. More concerning is among those people who go on an overdose and die, about 25% of them die within 24 hours, meaning that really, if we think about a standard of care, what's a reasonable standard of care? People should go home with naloxone in hand. That patient and their family members should be trained, or their friend or whoever they're there with should be trained on how to use naloxone. And so we've used a train the trainer model. We have 2 nurses who go around the state. They train charge nurses, and we're working with those nurses to distribute free naloxone. We get naloxone through our state's naloxone portal. We send kits. We've distributed about 4,500 naloxone kits to people with overdose or at high risk of overdose in the last couple of years, and it's increasing. We have 35 hospitals now. And now we're working with this group to think about how to do stigma training in this group of providers, because we recognize the importance of stigma in the ED. Not only that, what's been cool about this is we've been able to do buprenorphine education for our emergency medicine providers, such that we've, I think, trained about 50% of our state's ED providers to do bup inductions in the ER, like really just thinking about like, what is that next step, and worked with our collaborators to think about warm handoffs to the community so we can get seamless care. I'll mention this as well. This is Painless, the opioid musical. As I said, when I went to talk to a group of high school students, I asked how many of you could go home and within an hour get an opioid. 75% of the kids immediately raised their hand, and that is consistent with the national data. Kids know where they are. I don't think that means all kids are misusing an opioid, but they're talking about it. They know about it. They know where to find them. And for the most part, it's pretty easy. It's mom and dad's medicine cabinet or grandma and grandpa's medicine cabinet. They're there. So we got real stories from real people, and Jacob Bryan Smith there at the bottom wrote a musical. And we have now worked with our state's opioid curriculum to integrate this in the opioid curriculum, and are testing this as an enhancement to the curriculum in a way to try to engage kids in the curriculum, teach them about the risks of opioid misuse, and then also trying to help them engage a bit more. So we're testing this. We don't know if it works. We are actually officially doing some work to get data to demonstrate whether or not this is beneficial. But this is an incredibly talented group of individuals, and I'm excited about this. This has been disrupted by COVID for sure. As I wrap up here, I will let people know, if you're a healthcare office out there and you're interested in materials, we have freely available materials. We started early. People would call and say, hey, could we have that brochure, or could we use that picture? And I said, well, do you want to just share the brochure? In fact, can we take it up a step? So we allow places to send us high resolution logos of their practice or their health system. We put it on the front, we send it back for free and clear. For people who say, I don't want to open on it because we don't want to be affiliated with Open, fine. We'll take our logo off, we'll send it back, because ultimately we just want to improve care. There's lots of information on there, whether it be information for providers on how to encourage people to get on board with the idea of better prescribing, all the way to patient-facing materials, including some alternatives. And as I wrap up, I think if you do nothing else, if you're just kind of back to what do we do now, I think educating people is important. Telling patients that surgery hurts is important, not because we want people to be in agony, but it's unrealistic. And I think we have created a false narrative over time that we can fix all pain after surgery. And those poor expectations have led to their own problems. I haven't really talked about benzos much today. Our group's doing some work in this. Certainly, if a person's on benzos beforehand, they should not be taken off. But I do think we have to be really careful with how we use benzos post-operatively and in the perioperative period. I'm a believer that PDMPs, when used appropriately, are good. And I know that they've been misapplied, and I know that people have taken the information for the wrong reasons, but the PDMP serves an important purpose. And lastly, if you're just going to do nothing else, you're going to keep prescribing the same way, I would encourage you to use acetaminophen, nonsteroidals, and maybe some local anesthetics, because there's a lot we can do that's simple, that's low cost, that can actually improve pain. These are my colleagues: Mark Biggett, anesthesiologist, pain physician; Mike Inglesby is a transplant surgeon, great guy. He's a really thoughtful person as it relates to how we change care. And then Jen Walge is a hand surgeon. And this is our team. This is us doing some of our recent work, trying to come together, thinking about how we do our work. So with that, I see, I haven't looked at any of the questions, but I see 11 questions in Q&A. So I will pause there and Beth, be ready to take questions. Thanks.
Yeah, terrific. Thank you so much, Dr. Brummett. And feel free to unshare your slides whenever you're ready so that people can get a bigger view of you. So we do have questions in the Q&A. Feel free to chat in there. I'm going to lead off with a question from Andrea Anderson. I would like to ask about the Open Michigan Pediatric Opioid Prescribing Recommendations. They're incredibly disturbing. What is your justification for the shockingly low or no administration of pain medication for children with serious procedures and conditions? My concern is the resulting trauma from under or untreated pain will have serious detrimental lifelong effects on children, fracturing relationships, and children and their parents, as well as physicians.
Yeah, thanks, Andrea. Our peds recs are new. It's one of the few pieces of our work that I wasn't really directly driving. My colleagues drove that. It was actually driven by a pediatric surgeon along with a pediatrician. And all I can say is that we did this through evidence, as we have with everything. We got patient-reported outcomes from patients as to their use. And I guess what I would ask and just push back a little bit gently is to say, if you're aware of evidence bases, not individual stories, but evidence of need for more opioid than we're prescribing, or papers that we're missing, things we're not seeing, we'll take it. I mean, we will consider this. We've certainly done this, but there was a fair bit of work, more than a couple of years worth of work put into those. And I think that what we have found over time, and it was led by a surgeon who has a lot of experience, was that, these are the levels that patients report and address the patient's needs. I mean, in the same way we've done things for pediatric otolaryngology and just found, opioids, there are some of our pediatric otolaryngologists that have stopped giving opioids for tonsil and adenoids. What we found is that actually some is good and appropriate, but certainly not what we once gave. So I would encourage you to reach out to the Open team if you've got evidence that suggests that more is needed. I think we have to be really careful. We aren't giving zero pills because parents with loss are concerned about kids getting opioids. In the same way, we can't suggest giving lots of pills because of individual concerns. I also will tell you, when I'm talking to surgeons, I also tell people, don't stop being a physician. There will be individual cases for which needs will be in excess, and that's consistent. That some people will need more, and some people will need refills or have attentive care. But again, that gets back to our idea of coordinated care to follow.
Andrea asked several questions. I'm going to ping pong between some of the other participants. This one's from Bev Schechtman. We hear from people daily who were given 0 pills after major surgery, and they were tortured and now have PTSD. When you teach this information, do you make sure to urge the surgeons to not refuse more meds when patients ask? Do you tell them to make sure not to shame patients when they do ask for more, or warn them not to write drug seeking in the charts for asking?
Yeah, definitely, Bev. I mean, I'm glad we could finally engage, right? So we had some back and forth. You and I had some back and forth where you asked questions, and I tried to provide some information. Unfortunately, I think some of that information was not really applied the way that you and I had hoped in that spirited interaction. And I've certainly seen some of the information that you've posted that's just not true. I mean, I think the lecture I just gave is the lecture I give for surgeons. We say opioids are a tool. We say they're appropriate. We say that they have a role. And we say that you have to attend to some patients and acknowledge that some will not follow the guidelines, right? These are guidelines in the same way that the CDC is guidelines. If we look at the CDC guidelines, they have the 100 oral morphine equivalents, right? But if you read the guidelines, it was never a hard limit. It was misapplied. as a hard limit, right? And so I think in the same way, people can misapply our guidelines, and I don't know how to quite fix that. If, however, what I will ask of is if you go to our website and you see something, you say, I feel like this tells surgeons or tells people not to use any pills. I'll reflect on it. I'll change it. I'm a pain physician. I already told you. I think opioids are a tool, and I think we have a role here. But I think that what's challenging in engaging in these conversations with people, because your stories that you're telling are real and they're important. But I think when we're vilified in the public, it makes it hard to engage.
Great. Thank you, Dr. Brummett. This is an anonymous question. What is your approach to helping patients understand that opioid dependence is a side effect that can cause patients to perceive opioids as effective when they're mainly doing, especially at high doses, is keeping withdrawal at bay?
Let me read that again, Bev. Bev, hold on 1 second. So, understand the opioid dependence is effect. Yeah, it's interesting. I think that we see this with dependence all the time, right? So dependence is a physiologic state. And I think we certainly, I think this has become hard with some of the changes in the DSM criteria for opioid use disorder, where withdrawal is one of the criteria, but withdrawal is only one of the criteria if you're misusing the opioids or not using it like a physician's prescribing it. And so I do think there's education. I mean, this is more one-on-one, like how I would teach a patient about that. People have come into my office and said, oh, I think I'm addicted because when I stop taking these, I feel really bad. And we talk a little bit about addiction. We assess for addiction. And I determine, now, if I think a person has addiction at that point, I'm going to link them to care. At that point, the right answer there is not to stop their opioid. It's to actually link them to care and treat their opioid addiction or their opioid use disorder, which is the diagnosis. However, if it's physiologic dependence and they're withdrawing from it and they don't like that and they want to wean off, then it's a long process. It's slow and low. I mean, I've weaned people off opioids for years who want to do it, and it's slow and low and individualized. And I think nobody's done a better job of promoting that than Dr. Darnall in terms of understanding that we have to tailor, weaning to that. But I think that from my perspective, that education is personalized to the person. And I think this is where trusted relationships matter, right? So I have a lot of trust with my patients. We've built that trust over years. They want to hear from me. And I think that's part of what we're looking at with our transitions of care services. We have some qualitative data to show that for those people who come in and need more attentive care, they actually don't want that from the surgeon. They want it from their usual prescriber. They want it from the person who gives them their opioids month over month because they trust that person. And that's where I think this becomes challenging, in that we have to integrate that care. And right now in America, there's your surgical care and then there's your outpatient pain care, and they're not connected, and they need to be, because some of the points that Bev has made about those stories are examples of where that uncoordinated care is hurting people, and we want to close that gap.
Great, thank you. This one from Dr. William Amarquay, forgive me if I'm mispronouncing. Regarding dental extractions, what would you say to those who take NSAIDs? Data have shown low-dose opioids can be just as effective.
Yeah, great question. Again, same thing I tell surgeons of, like, don't stop being a doctor. I tell dentists, don't stop being a doctor. We will have people who can't get nonsteroidals. Those people probably should get a low dose of opioids. We've seen a lot of our dentists who've just thrown their arms up and said, well, I'm not going to prescribe ever anymore. And that's not been our narrative. I think that the reality is that there's probably 70 to 80%, maybe more, of the dental and oral surgeon prescribing in America that is unnecessary. And there's some that's appropriate. And some of that appropriateness is not just the condition, but the person. And so for those that have made guidelines or recommendations, what you find is that you can't make anything that's perfect and all encompassing. There's always an exception. And so we're trying to work through what those exceptions are.
Terrific. Anonymous question. Can you please address the other modalities and holistic approaches to managing pain in the immediate post-op period before a patient is discharged home?
Yeah, I mean, I will say other modalities is what I'll focus on first, because I think people have gotten complex. They've looked for, I think the gabapentin literature has fallen on its face, right? The reality is that gabapentinoids are probably not effective for post-surgical pain if you're giving the person acetaminophen and nonsteroidals, okay? So let me be more nuanced. If you compare a person getting an opioid, and that's their only thing they're being given for post-surgical pain, giving a gabapentinoid in a population will improve their pain. However, if you give them acetaminophen and ibuprofen and an opioid, or just acetaminophen and ibuprofen, that gabapentinoid really probably doesn't have any additive effect. And so while it's made it into a lot of multimodal protocols, and it'll take probably many more years for it to be out of those protocols, I also think that there are certain patients, as I said, I study nociplastic pain or centralized pain, where those people probably do benefit from a gabapentinoid because mechanistically it makes sense. So we tend to focus on the simple. We are looking at ways to improve compliance with acetaminophen and with an unbranded generic nonsteroidals. Unfortunately, one of the challenges right now is there are data out there and nonsteroidals kill people. Definitely kill people. Like you have people who get bowel bleeds, people who have kidney disease. That tends to be from chronic long-term use. And unfortunately, almost all of our data around morbidity from nonsteroidals is from chronic long-term use. And we have not enough data for the short-term use. And part of that is because it's hard to study because you can buy it over the counter. So we believe that short-term use, and we're talking days, could be 3 days, could be a week of nonsteroidals in a person who doesn't have serious contraindication is probably justified. And if you just did those two things, that's what I call alternatives, right? So I don't think you have to do anything branded. I don't think you have to do anything fancy. I think that there are local anesthetics that work, blocks work, but they wear off, right? So, and that's a bad situation. You don't want somebody getting a block, looking perfect in the recovery unit, going home and then having all their pain when there's no one around. That's a bad situation. And I think anesthesiologists have become more savvy to that situation and trying to avoid that problem. And we see it from our recovery room nurses too. There's certainly innovation happening in local anesthetics. There are some long-acting local anesthetics with which, but I have this conflict, so I'm not going to talk about them. I think maybe they're helpful, but I don't know, and I'm not here to market them. There are some, though, that are being widely marketed that I think are not effective and problematic. From a holistic side, we are working right now. We have a grant that is going in and going to be resubmitted. And I think Dr. Darnall's done a lot of work here. I think there's a lot of opportunity for behavioral treatments to attenuate pain, and not for the masses. Maybe they're helpful for everybody. I meditate almost every day, and it's helpful for me for a lot of reasons. But I don't think every patient's going to start meditating 2 weeks before surgery. However, if we can start teaching patients, in particular those with anxiety, who we've been giving extra opioids to, how to better manage their anxiety before surgery, that might be something in their toolbox forever, and I think could improve their post-surgical pain. The problem is going up to a person who's uncomfortable or screaming in the recovery unit and saying, "Okay, sir, it's time to breathe now." That's just the wrong answer. And so I think this is where I think there is a need for prehabilitative work in behavioral cares. I wish we could do more acupuncture, something I've done as well, that I think is actually beneficial for me. But it's not scalable, and it's not practical from a cost perspective for many people. I'm privileged in that I can pay for it. Many cannot. So I think those other aspects I keep simple. There's certainly a lot of data out there now too about music and trying to create a better environment. Hospitals are pretty bad environments. I think we could do a lot to improve our environments.
Terrific. And back to Andrea. Why is there little to no research on patient outcomes after zero opioid post-surgery? How do we know if post-surgical patients are actually doing well, or if they've turned to other substances to manage pain because they know they will not receive help from your clinic?
Sure. Well, we do have data. And so I don't know how to put it out there. We've published data on this topic. And so we we have that data and it's out there. It's scalable. And what we found actually was that when we compared people who got zero opioids to those who got opioids, the people who got zero opioids reported less pain, not because I think it was statistically significant, but not clinically significant. So if I was saying it clinically, I would say the pain was the same. But if anything, it erred to the side of less pain report, lower pain reports, equal satisfaction, maybe even slightly higher, and not really seeing the ill effects. And again, these are places where we've used statewide data. We're not just grabbing selected cohorts, and we don't recommend that for everybody. In other words, zero pills is not for the masses. Like this is, these are tailored interventions, places where we put it out. And then from the point of this idea of removing opioids from standard care, again, it wouldn't be for everybody, but we have randomized controlled trial ongoing, funded by PCORI. I am not the principal investigator. I am not driving the ship, but I think this is going to be a really important study, randomizing patients to opioids or nonsteroidals after minor surgery. And I think that's the data that you want. And it's obviously assessing pain afterwards. But our available data for observational data suggests that people do incredibly well. And we do have patient-reported outcome despite some of the suggestions that we don't follow patients. We do follow the patients.
Terrific. Thank you, Dr. Brummett. Thank you for being so generous with your time in answering questions.